product and what it can offer your patients. I am very excited to be able to introduce Dr. Paul Harasimovich. He is the founder and medical director of Bellevue Ophthalmology Clinics and the Montreal Glaucoma Institute, as well as the associate professor of the University of Montreal.
We also manage our patients' expectations. I always tell every patient that no matter what lens you choose, it's a compromise. There are some lenses that will give you something of benefit, and there may be side effects such as halos or glare or reduced contrast sensitivity. So it really depends on the state of their eye, and our role as physicians is to make sure that you're well aware of the health status of the eye. And after that, of course, we examine, our patient's personality. I just tell everyone, it's all about a compromise. I really do believe in EDOF lenses, and having the Eyhance as part of the portfolio, I think, will make many more patients who, for instance, they always do have dry eye disease and will be more prone to have halos, to say, hey, we do have this lens. And by the way, it is a refractive lens, the Eyhance. And so it's not, because it's not a monofocal lens, and you will be paying attention to their astigmatism, maybe making LRIs to make sure you have the best outcomes as well. This is a refractive procedure. But many more patients will be available to have something plus without causing as much glare and halos. And we tell all our patients that they'll have more dryness for the next few months. And actually, personally, I tell all my patients, you may have glare and halos. Most people will notice it, especially in lenses that have rings in it. I say, you'll notice them, and 3% of our patients no longer like driving at night. Someone says, that's my job, is driving at night. But I would still like to have something more than just a monofocal lens. I think, again, the Eyhance would be a great IOL for them. We also love our femto laser. Just having that nice, perfect capsular rhexis, even though both the Symphony lenses and the Eyhance lens are forgiving, so even if they're slightly decentered, we're not losing a lot of vision. I still prefer for my lenses to be perfectly centered, have a nice overlap of the capsule on the IOL, and I think that may explain part of our results that we're quite happy with. Now, so we went through the protocol, and I think it's very important, no matter what lens you choose, as we said, to be very rigorous in your measurements. Now, I think we should also pay attention to the type of material that we use in a patient's eye. We're operating more and more younger patients in their 40s, 50s, 60s, and they have many years to go. It would be awful to use a type of lens whose material would degrade over time and adversely affect the quality of their vision years later. So maybe year one, they'll have great vision with this lens or that lens, a lens that may become gray and opacify or may develop glistenings. I don't think would be acceptable, and I don't use them in my young patients. One thing that we love about the Tecnis platform, and I think it's proven itself, because there's spherical aberration correction. Here you see in this image, both in a 3 and 5 millimeter pupil, having that definitely helps the spherical aberration correction, but the other advantage is having the chromatic aberration corrected. And with chromatic aberration correction, which we have on our Symphony lens as well as on the Eyhance, will give you fantastic contrast and the quality of the vision. And patients will often say, the quality of my vision is just amazing. And I think that's to be expected. The other thing I wasn't quite sure of, but there's an excellent randomized clinical study now out at 5 years. I had seen the publication at 3 years. Now it's out at 5 years, where patients were implanted either bilateral Acrosoft lenses or bilateral Tecnis lenses. And definitely the other difference, aside from glistenings developing in many patients with the Acrosoft platform, was the rate of phimosis. And for me, as a glaucoma surgeon, I really hate phimosis. Having those zonules pull left and right can definitely also decenter the lens. And we know the rate of phimosis is quite low with the Tecnis platform. And here again, we did mention glistenings. We are seeing patients come in, their capsule is great. They're sent for YAGs. It's not the capsule which is the problem, it's the IOL. and we're having to perform more IOL exchanges, pull out this type of lens and put in a nice clear lens that does not glisten over time. So I think we'll be seeing more of this. So up to now, I've been a very fervent user of EDOF technologies. In Canada, we did have the Symphony. Now we'll have other IOLs coming out on the market as well. So we're probably up to 4,000 Symphony lenses in our patients. So we're quite comfortable. This is my go-to lens. One of the main reasons was because it does not reduce contrast sensitivity so much, or as much as many other lenses. And the other, as we mentioned, is that it is a more forgiving lens. So when you have someone like this guy here, this is Uncle George, who's my uncle. He is status post LASIK. I wanted to make sure that even if I was slightly off, that he would have great vision. He's an avid golfer. He loves life, and he's super happy with his bilateral Symphony lenses. Well, I have a couple of aunts, however, where we all have a couple of those kind of aunts in our family where you're like, I don't think they're the excellent type of Symphony profile. They're going to be calling you at home. Definitely they're more of the Eyhance type. And so I'll be able to offer them something more. So what exactly is the Eyhance? Well, it's a refractively spheric lens. It's basically, it looks exactly like a Tecnis lens, so it's the same platform. And it does reduce spherical aberration to almost zero. So there are no rings in this lens. So basically what we're trying to give our patients is intermediate vision, excellent distance vision, and excellent contrast. So the Eyhance differs from other types of EDOF technologies. It's not a zonal design, so it's a continuous change. So basically, you're not going to have a sudden change in power as you reach the center of the lens. And it's also not a spherical aberration-based design. It's using orders. So it's the periphery of the lens is identical to your Tecnis lens, but as you're coming in more towards the center, the power of it increases, and we'll show you how that's done. But just remember, the spherical aberration profile is exactly the same as your Tecnis monofocal lens. So again, we're expecting to have excellent contrast, excellent quality of vision. And here we're looking at the light spectrum. Okay, so we're looking at the colors. When we're looking at our Tecnis profile, so we're kind of more in the green to blue range, and we're getting really, really good distance visual acuity. Notice the IOL with the Eyhance, so the part here, so the peripheral part is still kind of in the blue range, but the central part is more towards the green range, and that's what's giving us that intermediate vision. So again, you're not going to notice a big change on the IOL itself, but it is manufactured definitely differently, and that's what's giving you the statistical increase in your intermediate vision. So expect to have very decent intermediate vision. I'll give you an example of one of our patients, just what kind of intermediate vision that is. And the other interesting part of the Eyhance is that it delivers pupil independent performance. So depending if your patient has a small or larger pupil, you'll still be getting excellent results in your patients. And again, we did mention, even if you have some slight decentration, you're still getting really, really good visual acuity. And this again, we love our MTF charts. Here we're looking at the contrast sensitivity, and we're comparing in green your Eyhance and in gray your ZCBU, your Tecnis 1 lens, and we see that they're pretty much overlapping, and you're getting really, really good contrast sensitivity. And just to put that into perspective as compared to other lenses, so yes, other lenses in a 3mm pupil, so whenever you're looking at studies that they say, hey, we have great contrast, you should also look what pupil size they're using. So in green, we have the 3mm pupil, and in 5 millimeters diameter. Notice how many of the IOLs, including obviously the Eyhance, there is some drop off of contrast sensitivity. sensitivity, but still we're maintaining a contrast sensitivity that is superior to most other commercially available or ones that are coming out on the market very soon. So really, really great contrast sensitivity. And the other question that people ask us is what kind of photopic, scotopic, what other visual disturbances may we expect? So again, this is not like a trifocal lens. It's not like a symphony lens. There are no diffractive rings. So of course, I'm sure you've all had patients even with monofocal lens who, are complaining of halo, glare, and I mean, that can happen just from ocular surface disease itself. So, I mean, I mentioned to all my patients, they can have some visual phenomena. I'm definitely expecting to have a lot less compared to any other design. We can never say no phenomena, but I think you're going to see that it really compares pretty much to a monofocal design. But obviously our experience thus far is limited. It is newly out on the market, but that's what we're expecting nonetheless. The other thing that I'm sure you're seeing in your community is that we're removing patients' lenses out earlier. I really want everyone to, you can never stop me from talking about glaucoma. Well, if you're looking at someone with angle closure, please make sure you use the World Glaucoma Association guidelines for classification. So in your charts, you should always specify, does my patient have PAX, primary angle closure suspect? That means without indenting, you do not see more than 180 degrees of the trabecular meshwork. If you have PAS anywhere in the angle, or if you have ocular hypertension associated with narrow angles, they immediately go into the PAC, primary angle closure, or PAC category. If there's any kind of visual field damage, ganglion cell damage, optic nerve head damage, then of course now they're in a third category, which is PAC-G, primary angle closure glaucoma. I'm mentioning this in an IOL talk because definitely we know that there is a great randomized control trial called the EAGLE study. This was for patients in the PAC and PAC-G groups. They did enter with higher intraocular pressures, so 30 or more. So this does not necessarily apply to all our patients, but in general, we know that if your angle is being squished closed, removing the lens will pretty much cure that angle closure condition. And this actually showed that performing clear lens extraction in patients with PAC or PAC-G was actually better and more cost-effective, lowered pressure more than performing a laser peripheral iridotomy. Yes, we love doing that quick little LPI, one of the things that we like, but now I always tell my patients, well, you have another choice. If your patient is in their 50s and anyway, they're hypermetrope, and definitely we consider removing their lens and skipping the laser iridotomy altogether. So I think we've seen a huge growth of lens removal community based on the recommendations of the EAGLE study. Again, they don't necessarily apply to all your patients, but I definitely have this discussion even with my PA-PAX patients saying, hey, you do have some nuclear sclerosis, your vision isn't perfect, let's kill two birds with one stone. Although we don't like using that phrase anymore. No killing of birds. So this is one of our patients, primary angle closure. So he is a gentleman, 59 years old, slightly hypermetropic. He has some ocular hypertension, so far no PAS, and this is obviously written in French here, but we're saying your option is laser iridotomy or lens extraction. And the patient said, hey, I'm actually tired of wearing my glasses. Like, I want to be less dependent on my glasses if that's going to help this condition anyway. And we do tell our patients that there's a 1 in 3 chance post-laser iridotomy that the angle won't open up, and that's been proven in many studies. And many of our patients that do have a patent PI postoperatively, you have to remove their lens earlier anyway. So he decided to opt for lens extraction. And the right eye, he had completely normal exam, but the left eye, he actually had an 80s pupil. So his pupil size was slightly larger. And as you know, 80s pupil, not extremely common condition, but we decided that, he would be more prone to having visual disturbances. So, we looked, ocular surface looked good. We discussed halos. We discussed that he would need some reading glasses. We decided to go in his right eye for a symphony lens, and in the left eye, an Eyhance lens. And so this is the image taken from our OR. We were super excited. This was actually our first Eyhance case. We had at the time gotten approval from Health Canada. Now we no longer need that because, as you know, the lens is available on the market. And let's look on the left-hand side here. This is post-op Symphony Tarek. So we had some astigmatism, the right eye, 20/20 distance, 20/20 intermediate. And from near, he was actually J3, so performing super well. We asked the patient, and he said, yeah, I'm not exactly sure what you're talking about, the halos. Is that like maybe that little thing that I see somewhat at night? Really did not bother him at all. So that wasn't the reason that we chose to do Eyhance in the other, but 80s pupil can be a condition which evolves over time. So I wasn't sure, will his pupil later on dilate more? Will he develop a small pupil? And look at the amazing, so this is a week 1 results out for his left eye. So the left eye, 20/20 distance vision. So again, we're expecting to have the same distance visual acuity as with that you would with Symphony or even with a monofocal lens. Look at his intermediate vision. It's actually 20/25, and this we took at the same distance. Initially, I asked my patient, I said, I really love my patients to compare their eyes. He's like, yeah, my vision's great. I said, no, we have to be a little more specific. Please cover your left eye. So then we kind of checked out the Symphony eye. His intermediate range was actually where you would expect it to be. With the Eyhance, he took the chart, so he closed his right eye and he pulled it away slightly. So there was a little bit of a gap. So I think that the intermediate vision will be slightly further away with the Eyhance compared to the Symphony lens. And again, he said, no, my vision is perfect in this eye. The two together, I'm like the happiest person. And he said, you could have just put in the Symphony actually for me in both eyes. I do see actually slightly better at near for reading with the Symphony eye. But you told me that I may get more glare and halos because of the pupil. So we were super happy and very excited. And we have 3 other patients booked. Another patient that has had Symphony in one eye. And I'm always still wondering, obviously, COS is not necessarily endorsed bilateral cataract surgery, but I think in the era of COVID, there are many positive things to think about doing bilateral surgery. I do have some patients, however, that, we've removed lens, put in a Symphony, great results, except they say, if I had this kind of glare and halo, I would be unhappy. Second eye now, I've been holding off, so they're all being booked in the next few weeks for Eyhance in their second eye. So, had we done bilateral Symphonies, would they be miserable? Would be unhappy? Should I remove some lenses? I think in some patients, sometimes waiting off on doing bilateral, if they're seeking other types of lenses and you think that they may be unhappy or have a particular personality or more ocular surface disease, perhaps doing one eye at a time, and depending on the outcome of the first, you could do EDOF, you could do EDOF synergy, you could do EDOF monofocal, or now for sure I'll be switching pretty much everyone complaining of halos and glare to have the Eyhance, which again is a refractive lens, which will be giving your patients that intermediate vision. Now I know my talk was mostly about EDOF, but I was also super excited about the synergy lens. So I've also had a few patients lined up for that. The synergy lens, you'll learn a lot more about Dr. Chang, but I just want you to quickly look at this curve here. It's not like the traditional trifocal lens where between your near, your intermediate and your distance vision, usually there's a drop off in the quality of your vision, the visual acuity. What actually we're doing with the synergy lens, we're putting EDOF technology on top of trifocal technology. So we're actually, that's why we're getting really great continuous vision at all distances. So we're super excited about the synergy. Again, we're correcting chromatic aberration, and look at the chromatic aberration, even compared to the Tecnis Symphony, we have even better chromatic aberration correction. And again, we know that it will be less pupil dependent. We can call it pupil independent, but there's always some effect of pupil size. But look, between 3 and 5 millimeter pupil, definitely compared to all the other trifocals available currently on the market, no difference. It actually looks even better with the synergy at 5 millimeters than it does at 3 millimeters, compared to the ones, we've used, the Zeiss, Acrylisa, the Fine Vision, and the Panoptics have had good results, but I think we're going to see in the market a shift happening as new technology comes out. We like trying things out. I think our patients should be quite happy. The other thing that you should be aware of is that it's, you'll notice it says Opti Blue on the box. What Opti Blue means is that we're not filtering out the blue light, which is important for circadian rhythm, but it has a UV filter. And having that UV filter, I think, is something that will probably decrease the amount of glare and halos. So we're super excited. This is one of my patients. So we have a couple of patients now where we planned ahead of time to actually do a mix and match. And this will probably be in my practice, the number one thing that I'll be doing will be Symphony in one eye and Synergy in the second eye. So this is a CEO of one of the largest Canadian companies, super young, comes in, has posterior subcapsular cataracts, he has 20/70 vision, 20/30 vision. You can see on the retro image here, there's capsular cataracts. Again, I think we have to pass the message. So when you guys are talking to your optometrists in the community, sometimes they're being followed saying, it's not too bad, you have a little subcapsular cataract. Make sure you get baseline biometric measurements. Sometimes those subcapsular cataracts go so fast, and then it may be difficult to get good axial length measurements. So pearl of the day, make sure that anyone with subcapsular cataracts, pass the message on to your optometrist, send them into our office. We're gonna get proper biometry. Even if their surgery is in a year, 2 or 5 years, at least we'll have that great axial length measurement. We see here on topography as like maybe a little bit of suspect of some keratoconus, but it's still quite regular, his astigmatism. And so again, in the right eye, not a huge degree of astigmatism. It was actually suggested for a non-toric, so we did a small LRIs, and in the left, and the reason that we decided actually to do a mix in him, this right eye, great axial length measurements. Look at the left eye. We're not exactly sure what is your axial length. So we have this composite algorithm on the lens star, and we've actually been having fantastic results using the composite algorithm. And so we said, okay, left eye, Symphony toric, and right eye, he's going to get a Synergy lens. The other thing that we were quite nervous about initially was that he has 1.5 diopter difference between his eyes. So we remeasured him 2 more times, but we also had old records. So we actually took the time to call his optometrist. The optometrist sent, and there always was a difference in the strength between his eyes without him having necessarily amblyopia. So this was our first case. Super excited. So you won't notice any difference. You do your surgery the same way, but the IOL itself, you'll notice has these small concentric rings, but there's 2 of them together. So you have the same amount of rings as you would, I believe, with your Symphony. You would want, obviously, your lens to be properly centered, but look here at the IOL. So you notice that there's 2 rings, 2 rings, 2 rings, there's 2 rings, and these are the results. I mean, the guy is super happy. He's already made a donation to the foundation. We see that his distance visual acuity, look at the Symphony eye, which is the left eye, OS, 2015. Very good distance vision in the right eye, 2025. Look at his near vision, 2020 in the right eye with the Synergy, 2050 in the Symphony eye, and that's usually we're 2040. But he's super happy. Look at his intermediate vision. His intermediate vision with the Synergy eye, 2010. That's incredible. And the Symphony is 2020. So I think we'll be getting potentially even better intermediate vision, definitely better near vision, great contrast. We won't be having that gap. And I tried to ask him, do you notice any? He's like, no, I see at all distances. And I think because the contrast will still be better with a purely EDOF lens, I think that patients, even though they may not have any disease in their eyes, it'll be interesting to see what happens in your practice and in our practice. Should we do mix and match, EDOF, synergy in the eyes, or bilateral synergy?